Acute pancreatitis. You want to know how to make the correct diagnosis, you want to know about treatment, and what are the possible complications. If that's your goal, you're in the right place. Let's go. Hi everyone. As part of the continuation of acute pancreatitis, I want to talk about acute pancreatitis 2. And here I will start by saying make the correct diagnosis of acute pancreatitis and treat. That will involve investigations, treatment, and we'll go over complications. The investigations in acute pancreatitis will involve the following. 1. Serum lipase. That is the one I'll first of all go for if I'm given the opportunity to choose between serum lipase and serum amylase. I would rather go for serum lipase, but I'll be happier if I have the chance to accept both. So serum lipase should be in about 90 to 100% sensitive or specific. It occurs earlier in the injury and lasts longer than amylase. Serum amylase, on the other hand, is about 80% sensitive and 90% specific if the elevation is greater than 3 times the upper limit. The normal level of amylase is 30 to 110 international units per liter. The blood glucose should be assayed with glucometer, and it's expected that it will rise and will treat appropriately. Arterial blood gases should be assayed because there is likelihood of respiratory distress from what I've stated as part of clinical features in my previous presentation on acute pancreatitis. Liver enzymes should be assayed because I've talked a lot about alcohol, and how alcohol and triglycerides hit your pancreas. And increased ALT could mean that there's trouble within the liver itself, but AST will mean there's trouble with alcohol, and ALP will show the sign of obstruction because we are dealing with gallstones here causing pancreatitis sometimes. And when we assay the electrolytes, we are expecting a decreased level of calcium, hypocalcemia in pancreatitis. If we assay the blood, urea nitrogen, and creatinine, it's expected to increase. Possible ketoacidosis here, remember that insulin production is impaired, glucose metabolism is under an insult, then there's possible ketoacidosis. When we do complete blood count, we may find anemia because of possible retroperitoneal bleeding. The increase in white blood cell that we may find is likely going to be as a result of inflammation or infectious origin. The other time I've talked about Legionella, talked about fungi, talked about mumps, and so on and so forth. And when we assay C-reactive protein and IgG4, that is expected if we are suspecting autoimmune condition. Lactase dehydrogenase could be assayed, and that is non-specific. It is non-specific, but it is not out of place because it's useful. It could be a sign of tissue damage, and that will be either even in blood, any organ, muscles, and any organ, including pancreas as one of the organs that could be damaged, and we'll see LDH. It is non-specific. We can do our ultrasound. When we do abdominal ultrasound, we look at the biliary system, we look at the pancreas, look at the abdomen to see whether it's fluid there or anything, retroperitoneal fluid accumulation, and so on and so forth. And you do your CT scan which will show everything, show the structure of the pancreas, show signs of lesion there. And now I've highlighted ERCP, endoscopic retrograde cholangiopancreatography. This is it. This is a kind of definitive procedure in any insult involving the pancreatic gland. It could be diagnostic and therapeutic at the same time. It's useful in gallstone pancreatitis, can view bile duct and pancreatic duct. We can also do magnetic resonance imaging and do radionuclide biliary scanning. Now, RBS is not random blood sugar. Now, to my friends who we done with that, is radionuclide biliary scanning. The ERCP, I'm coming back to it because it's a very, very useful procedure, and you sign consent form because it could actually lead to pancreatitis on its own, and they will tell you other possible complications that could come up as a result of that. But it's a very useful procedure, very, very useful. It could help to make absolute diagnosis and could be used therapeutically when the procedure is carried out and the stones are found. The experts will do what is needful. So if you are a patient, you have pancreatitis, and you are being introduced to our ERCP, I will just encourage you to have it done. It's going to help. It's going to help. It's a good procedure. Yeah, we're now about to talk about treatment. Mortality in acute pancreatitis is high. It's high because where we're finding about 5 to 20% of affected people dying is very high. So we have to admit, give our IV fluid, could be normal saline or Ringer's lactate. We could give hydromorphine or fentanyl patch. Meperidine is okay. All those ones will undo the pain, but no morphine. Why? Morphine could worsen the pain by causing contraction of the sphincter of O'Day as ampulla of Vater. Then enterovidine, like using PEG and feeding the individual with high protein and low fat, would be great. You may choose to give antibiotics depending on the cost, depending on your outcome. And you treat glucose problems. I call it glucose problems because it may be high, may be low, may be up and down. So you regulate the value, titrate it with your medication, insulin this time. There may be need for blood transfusion or not, depending on the value of complete blood counts, and of course, physical presentation of the affected individual. If it's a multidisciplinary center, it will be better to involve the respiratory unit, the endocrine, the infectious unit, and it depends. You can involve the renal unit based on what your findings indicate. So if all your physical examination, history, and diagnostic measures indicate that the kidney is in trouble, involve renal. If you are suspecting that respiratory problem is in trouble, involve respiratory unit. Endocrine unit, because the pancreas is in trouble, the insulin is in trouble, glucose metabolism is impaired. Infectious unit, if you think this is, mumps or carditis, that may be virus, Legionella, or HIV, and so on and so on and so forth. So involve every unit that you think will play good roles in helping this human being go back home on time. What are the possible complications? There's possibility of pancreatic pseudocyst, peripancreatic fluid collections. You are going to pick all those on your scan, CT scan, and everything like that. Necrotizing pancreatitis. What of necrosis if it's greater than 4 weeks post-necrotizing pancreatitis? There's possibility of pancreatic abscess, splanchnic venous thrombosis, and that is splanchnic or portal or superior mesenteric vein thrombosis. And of course, there's possibility of pseudoaneurysm. So complications of acute pancreatitis are many. Increased ACL, this is not acute coronary syndrome, is abdominal compartment syndrome. And I want you to please listen to this. In severe acute pancreatitis, there is that possibility of intra-abdominal hypertension. Also, possibility of abdominal compartment syndrome. Intra-abdominal pressure could be measured in the intensive care unit. So when there is increased abdominal compartment syndrome, the next thing to do is the compressive laparotomy, and it is an urgent procedure done quickly because that is what could increase the likelihood of mortality. Let me repeat. There's possibility of increased abdominal compartment syndrome. In severe acute pancreatitis, there's that possibility of abdominal hypertension and abdominal compartment syndrome. So intra-abdominal pressure could be measured in intensive care units. And once that is picked up, please, the surgeon should be invited as a matter of urgency. Why? That will lead to death if intervention is not embarked upon quickly. So hyperglycemia, when beta cells are damaged, could be handled easily by any of the doctors on ground. Then, of course, we could be dealing with alcohol withdrawal symptoms also. Don't let us forget that it's likely we are dealing with this trouble because this uncle of mine has been drinking alcohol for the past how many years that I don't know, and now is down with his trouble. There's possibility of increased exacerbations of lung diseases. The other time I said there's possibility of respiratory distress. And then because of that, we need to do arterial blood gases and the rest. But in someone who has been diagnosed with COPD before, either emphysema or chronic bronchitis, now with alcohol or hypertriglyceridemia or whatever, it's now coming down with pancreatitis. It's likely we're going to have acute exacerbation of COPD in this man. in my uncle. So we have to watch out. If that is part of the history, immediately let's involve the pulmonologist or the respiratory unit from onset. In conclusion, wishing all affected people well. Let's control whatever we have the power to control. Like what? Like alcoholism, like smoking, like reducing our triglycerides, doing exercise, and taking appropriate medication. Gemfibrozil is available to treat your high triglyceride level. And I want you to be on the watch out for chronic pancreatitis that I'm going to publish in the next few days. Thank you for listening to my presentation and watching my videos. Kindly subscribe so that you can get these as soon as they're published. Thank you.